Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from F. Hoffman LaRoche Limited.
This program is presented by Medscape Education Global.
Dear colleagues, my name is Solange Peters and I'm working at the Chair of Medical Oncology in Lausanne in Switzerland. And it's my great pleasure today to be able to discuss with you the standards of care as well as the evolving paradigms in extensive stage small cell lung cancer. We will also discuss today, beyond the current landscape, the remaining unmet needs in this specific disease entity. Just to start about small cell carcinoma of the lung. This is a very typical carcinoma that a pathologist should immediately recognize. As you can see here on the picture, there's a nuclear feature that is key to diagnosis and very typical. It expresses neuroendocrine markers and TTF1. All of these are positive. Usually we don't even need TTF1 to be able to firmly confirm the diagnosis of a small cell carcinoma. Probably one of the most aggressive solid tumors that we are treated in medical oncology, with 3 patients out of 4 or even more than that presented with a metastatic advanced disease, what we call the extensive stage small cell lung cancer at the initial presentation. There are lots of therapeutic approaches. Of course, chemotherapy for decades, with now some immunotherapy, checkpoint inhibitors of PD-L1 category mainly. We will discuss it later on. Radiotherapy strategy to treat symptoms. But of course, we have to keep in mind that whatever we do, the prognosis remains dismal, with very few long-term survivors and a median overall survival which is around 1 year. And emerging biomarker giving us some hopes that maybe at some point we might customize and be a bit more precision in the way we treat small cell at the image of what we would do in non-small cell lung cancer category. Let's discuss together what is unique about small cell. So you have understood this is the survival curves. Even if some of this kind of a small proportion, but some of these small cell lung cancer are stage 1, 2, and 3, which we call limited stage small cell lung cancer. Even in this limited stage, the prognosis is extremely, I would say, poor, with probably 1 patient out of 5 who can be cured, even slightly less. We tend to say heavy smokers, and up to half of the patients in the course of the disease will develop brain mets. So everything speaking for the aggressive nature of the disease. Frequently, small cell lung cancer is associated with paraneoplastic syndromes, and we have to potentially also be able to characterize the molecular feature, but the common determinant of small cell lung cancer, which also allow us to make sure about the diagnosis, would it be needed, is the inactivation of both P53 and RB1. Very typical. We will always use it, for example, to characterize a transformation into a small cell when you start from a non-small cell. The response to chemotherapy is transient, very high response rate, but very short lasting. And the historical median overall survival, as I said before, is 1 year. We have improved it a little bit, but only a little bit. And on this cartoon, you will see how much this disease tends to metastasize a bit elsewhere, but very often to the liver, very often to the brain, the bone, and the lung. But remember that the brain lesion is a problem today. We've been studying the chemotherapy in small cell extensive stage, but also limited stage, extensively in the past. It was the old days where chemotherapy was the question. And basically, the first question we had was cisplatin versus carboplatin. Cisplatin has this toxicity, which is particularly prohibitive in these patients who usually are frail and strongly affected by the symptoms of an aggressive disease. And this meta-analysis from Rossi and colleague was nicely showing that in this meta-analysis based on individual patient data, so high quality, survival, PFS, and response rate are the same using carboplatin or cisplatin. Carboplatin has a little more hematological toxicity, but remember that cisplatin has neurological, GI toxicity, as well as renal insufficiency as side effects. So we prefer carboplatin, and this is commonly used in extensive stage small cell lung cancer, with very few exceptions to that. Thinking about chemo again, and it looks like very old regimen with cyclophosphamide, adriamycin, vincristine, even etoposide being used in complex regimen. We have started with that, and all of these trials basically show roughly that etoposide and platinum is as effective as this complex combination with cyclophosphamide and anthracyclines and vincristine, but is less toxic. So it became, and it's very few and very rare in oncology, the standard because of toxicity benefits and not efficacy benefits. And that's unfortunately shown here, because if the toxicity was better, the efficacy was not really exciting. In all of these trials using the old combination or EP, you can see that there are basically no good outcome long-term, no tail of the curve. So there are no long-term survivors, and the slope of these curves is absolutely disappointing. So we have to do better. The problem of establishing immunotherapy in small cell is we knew from translational research that small cell has a low PD-L1 expression, has a low MHC class 1 expression, and even sometimes a null expression, low TILs, low immune cell infiltration, the presence of immunosuppressive cells, Tregs, myeloid-derived suppressor cells, immunosuppressive cytokines in the tumor microenvironment, and that this tumor grows so fast that very often the vessels to bring cells there are missing. So we tried, and we tried first with ipilimumab to try to enlarge the repertoire of T cells. This is Martin Reck and colleague, trying to combine the EP with the etoposide platinum with ipilimumab, with unfortunately, despite early promising data in this randomized trial, absolutely no benefit. And as you can see, survival is 11 months, so we haven't improved at all since the old days. So the change comes from these two trials. Two trials relied on anti-PD-L1 moiety. On the first one, IMpower 133 is atezolizumab, and for Caspian is durvalumab. This trial was using the EP, etoposide platinum regimen backbone, carboplatin for the IMpower trial, carboplatin or cisplatin for Caspian, with the usual 4 to 6 cycle of chemotherapy, but combined with the anti-PD-L1 and the maintenance of the anti-PD-L1 until progressive disease, or of course until the patient could not tolerate it anymore, with the primary endpoint of overall survival. And both of these trials have shown an improvement. You will tell me it's a modest improvement. Agree. But that's the first time we have been seeing an improvement in that disease. So both of these trials show benefit in terms of magnitude of atezolizumab on the left, on durvalumab on the right, when combined with platinum etoposide. What counts in small cell is survival. Survival is short, and this is a new paradigm. We had this trial, you can see the hazard ratio. For PFS, it's 0.77, 0.78 for the two trials, and survival 0.7, 0.73. What does it mean for the patient? It means a survival of 12 months versus 10, of 13 months versus 10. So still not really a revolution, but really something which is the first time we show an improvement in our old days regimen. There are two other trials using nivolumab and pembrolizumab, which because of the study design mainly, were not shown to be significant at the end. Even a systemic review, meta-analysis, showing that the addition of checkpoint inhibition to chemotherapy in naive patients with extensive stage small cell results in a 22% risk in reduction of deaths. So really, the same across all of these trials, very reassuring. We have changed something. If you look at the magnitude here is depicted with the difference between the two curves, which really represent graphically the hazard ratio. So you will say it's modest, but it's existing. What is probably important is at milestone, like 3 years, you can really improve the number of survivors from very low to 3 times more. So I think it's quite important to still keep in mind that what is modest can be a long-term survivor that you have in your clinic, which is a difference, okay? Are toxicities manageable? Yes, they are. The toxicity of chemo is known. It's not very easy to pile up the platinum cycle in these patients, but nothing unexpected in terms of, for example, paraneoplastic syndromes. They are not often observed, and so nothing, I would say, unexpected. Biomarkers. TMB is high, 8, 9, 10 per megabase. PD-L1 is low. None of them is predicting the activity of immunotherapy in small cell. If you look at, for example, one trial, and this is the Empower trial, you can look at PDL1, and you can look at TMB, left and right. You can see in this forest plot that they don't discriminate at all the group of patients benefiting. By using at the expression pattern of various tumor biomarkers, so transcriptomics, now we can even sometimes use immunohistochemistry to show that, there was a definition of subtypes of small cell. The dominant one, the subtype A, with the TTF1 expression, the neuro D1, so the TTF1 negative, also somehow chemosensitive subtypes, the POOF F3 subtypes, chemoresistant, and the inflamed subtype, all of them being described by a pattern of expression of genes and of proteins. Kind of important to keep in mind that they really discriminate potentially the small cell lung cancer patients in terms of survival. And we are all hoping that this inflamed subtype defining the potential for response to immunotherapy would help us look at who are these patients who are alive long-term with immunotherapy. And it was pretty suggested in Empower 33 and Caspian, where you can see that in the inflamed subtype, even if it's a small proportion, 1 patient out of 4 or 5, it was improving here survival better than in the whole ITT. Same thing as in Caspian. Unfortunately, there are since then many series not reproducing it. And the reason is that it's very difficult to interpret and classify these subtypes, and more than that, the tumor itself. So what can we do more? So the most important thing to keep in mind is that we can count on second-line treatment. And you can see on the graph that receiving second-line treatment improves survival as compared to not receiving. But in small cell lung cancer, few patients receive second line. 37% in a real-world data. In Empower 33, and half of them, and in Caspian, less than half of them. So we need an effective maintenance strategy mainly to make sure that you catch all of these patients, knowing you lose half of them for second-line treatment. So we have been trying with immunotherapy before the trials I described before, where immunotherapy was not a standard, where we tried not to give immediately, but as maintenance, nivolumab or nivo-EP. So it's a very nice graph because you can see an activity, but unfortunately not enough and not significant. And this was an inspiration for us to think that if immunotherapy has to be given, it has to be started earlier, leading to the trial I presented before. So suggesting of an effect, but no standard maintenance here, and of course the frontline strategy has changed. If you think about maintenance, with all the trials doing maintenance in small cell, it improves slightly PFS, but does not improve OS to date. So it's a good strategy, you catch more patients, but we need more effective treatments to bring in maintenance, better in maintenance than second line because you catch more patients. And you will have this conversation and listen to colleagues, but also in this program, to discuss with you the IMforte trial, which is a very interesting maintenance of lurbinectedin and atezolizumab. And of course, what can be interesting in the maintenance with T-cell engagers, the tarlatamab, which is already a trial having given some early data, and we'll see more patients and more data in the future. So maybe we have reached a time where maintenance can be revisited with more effective agents as being the strategy to complete chemo-IO frontline. And with it, I thank you for your kind attention.
So, dear colleagues, it's my pleasure now to switch a little bit to new innovative therapeutic strategies for management of patients with advanced small cell lung cancer. We have seen that we have achieved an improvement with the implementation of checkpoint inhibitors into the management of first-line treatment of patients with metastatic small cell lung cancer. But we also do see that the majority of patients do progress after a short while. So we are in an urgent need to enhance the efficacy of our systemic therapy to maintain the duration of response. And this is the concept of maintenance, which we are now introducing also into the disease of small cell lung cancer. And we have two different concepts of treatment that we are investigating. Number one is the introduction of a novel cytotoxic lurbinectedin as a maintenance strategy. And number two is a new immunotherapy, a T-cell engager, tarlatamab. And in both of these new approaches, we have trial data to share. And I would like to start with the combination of atezolizumab and lurbinectedin as a maintenance strategy. And this has been explored in a randomized phase 3 trial. This has been the IMforte trial. And this trial was positive for the two primary endpoints, and these were progression-free survival and overall survival. So here you can see the design of the trial, a very pragmatic design. So the patients with an advanced metastatic small cell lung cancer received 4 cycles of first-line chemoimmunotherapy with platinum etoposide and atezolizumab, and then if they had a response or a stable disease, they were randomized 1-to-1 to a conventional arm. This was the maintenance treatment with atezolizumab, 1,200 milligram every 3 weeks until progression, or the experimental arm, which was the combination of lurbinectedin at a dose of 3.2 milligram per square meter and atezolizumab, 1,200 milligram every 3 weeks until progression. And the primary endpoint of this trial was progression-free survival as well as overall survival. And it's very important to note that the efficacy was measured with the beginning of the randomization, which means after the 4 cycles of first-line chemoimmunotherapy. And when we look on the key primary endpoint, this was progression-free survival by investigator, we do see a clear, significant improvement in favor of the combination of lurbinectedin and atezolizumab, with a median progression-free survival of 5.4 compared to 2.1 months and a hazard ratio of 0.54. And when we look on the effect across the different subgroups, we do see that the signal was generated across all investigated subgroups, independent from age, independent from gender, independent from ethnicity, and we also did see the benefit in patients with high tumor burden with high grade of metastasis. Looking on overall survival, and I think this is important for small cell lung cancer, we also have seen a significant improvement in overall survival favoring the combination of atezolizumab and lurbinectedin, with a median overall survival of 13.2 compared to 10.6 months, with a hazard ratio of 0.73. And when we look on the 1-year overall survival rate, we can see the clear benefit, 1-year overall survival rate of more than 58% for the experimental arm compared to 44% in the control arm. I think it is of importance to note that the efficacy was assessed with the start of the maintenance treatment after randomization. So we have to count in also the overall survival benefit from the induction treatment, and this was in median 3.2 months. And again, the signal was observed across all investigated subgroups. Something which was very unique about the IMforte trial was the response rate, because in small cell lung cancer, the majority of patients are achieving the response during the chemoimmunotherapy, and then during maintenance treatment, we are only preserving the control of the disease. Here in the IMforte trial, we also did observe an improvement of response with a difference in the response rate of 9%, and we also observed a prolongation of the duration of response from 5.6 up to 9 months median duration of response. Well, the question is, what are the adverse events associated with this increase in efficacy? Well, we didn't observe any new adverse events that we already have seen with the use of lurbinectedin. We haven't seen any new adverse events associated with atezolizumab. There was a somewhat higher incidence rate of treatment-related adverse events. However, the majority of these adverse events could be managed very, very well, and the discontinuation rate was very, very low. This is the picture of the observed adverse events, and you can see this is something that we would have expected. These are chemotherapy-associated adverse events, some GI toxicity, the majority grade 1 to 2, very few grade 3 toxicities associated with this novel combination. The other concept, combining a T-cell engager with a PD-L1 inhibitor as first-line maintenance treatment, also has been explored, but so far we only do have data from a very early exploratory phase 1 trial. This is the design. This is the Delphi 303 trial, a phase 1b trial. So conceptually, patients were also receiving 4 cycles of chemoimmunotherapy, and then they were assigned to 2 cohorts of maintenance therapy. One was the combination of atezolizumab with tarlatamab, and the other one was the combination of durvalumab and tarlatamab. And the primary endpoint was the dose-limiting toxicity, but they also looked on the treatment efficacy of these novel maintenance strategies. And here you can see the 2 cohorts. You can see the disease control rate. We very rarely do see responses in this maintenance setting, disease control rate of 62.5%. And we looked on the duration of the disease control, which was in median 9.3 months. Well, do we see a switch when we change our backbone checkpoint inhibitor between the first-line immunotherapy and the maintenance immunotherapy? Overall, this was not the outcome of the trials, so the disease control rates were completely comparable regardless the checkpoint inhibitor in the first line or the checkpoint inhibitor in the maintenance setting. We also do have very, very preliminary landmark efficacy data, so we have a median progression-free survival of 5.6 months, and we have a first signal for overall survival. We cannot speak about the median overall survival, but we have a 9-month rate of overall survival, and this was 89%, and this looks quite promising. Well, very importantly, the question is, what about tolerability? Actually, we didn't observe any new signals that we haven't seen before with the use of tarlatamab in patients with advanced small cell lung cancer. We have patients with the CRS. We do see patients with ICANN. However, we are learning to manage these toxicities, and we are going to discuss this. So the majority of these side effects were grade 1 and 2 and could be managed. And interestingly, when we look on the timing of the appearance of these adverse events, predominantly we do see this in the first cycle, but never again during the continuation of treatment. So these are also very promising data, and now this concept of investigating tarlatamab with a checkpoint inhibitor as a maintenance treatment has been transitioned into a phase 3 trial, and this is the DeFi 305, comparing the combination of tarlatamab and durvalumab to a conventional maintenance with durvalumab after 4 cycles of chemoimmunotherapy with durvalumab as backbone. And the primary endpoint of this trial is overall survival, and this trial is ongoing. Having said this, I would like to thank you for listening and your kind attention, and I'm looking forward to our discussion. Thank you. Well, welcome everybody, and I would like to welcome you to our discussion. We have just heard the exciting data on the latest updates for novel treatment strategies for our patients with advanced small cell lung cancer. Now we are going to discuss this. What does it mean in our daily practice? What are the implications of these data? And I would like to introduce, first of all, Dr. Melissa Johnson. She's a medical oncologist, director of the Sarah Cannon Research Center in Nashville, Tennessee. Melissa, it's great that you are here, and I would like to welcome you. And I think we are going to start to talk a little bit about the IMforte data, the lurbinectedin combination data in the maintenance setting. And you have seen the data. You have treated yourselves patient with lurbinectedin. It's a novel concept, so we are adding the lurbinectedin directly after the first-line chemoimmunotherapy. And I think it's a very important trial. For a long, long time, we have seen a significant improvement in progression-free survival, and we have seen a significant improvement in overall survival. We always have to remind that the assessment of efficacy started after the 4 cycles of first-line chemotherapy. So in our thoughts, we always have to add some months when we look on the efficacy data. But I think it's very important to see this data. On the other hand, we also have looked on tolerability. There is some increase in adverse events. However, I think overall it appears to be manageable. But I think I would like to ask you, what is your taking of the data? What is your experience with lurbinectedin, and how do you see the implication of this data in your patients with small cell lung cancer?
Thanks for having me, Martin. I have used it in the second line for the treatment of patients with small cell lung cancer previously. I've been surprised that some patients have the side effects that we have heard about in clinical investigations, the fatigue, the cytopenias. Others do really well and have very little in the way of side effects. So just like every other drug that we give, you gotta give it to a patient to know how they will tolerate it. The IMforte data to me is very exciting because this is an area, the frontline maintenance, where we have needed more than what has been available. Immune therapy in the maintenance setting improves survival for the first time in small cell lung cancer for 3 decades. But as you know, it's not a lasting improvement. And so I always wince a little bit as I take away the chemotherapy after the induction period as we begin the immune therapy alone. So the addition of lurbinectedin, a novel cytotoxic, in this maintenance setting makes a lot of sense to me. These are 2 drugs that have different mechanisms of action. I think that they pair together well. And this will mean that for those patients in whom you feel as though the cancer may not all be completely controlled, this is a great next step.
Yeah, so I think this is the ongoing discussion. We know lurbinectedin from the second line, and you can argue, well, it's for the majority of our patients, it's a palliative treatment. Why shall we expose them to the treatment so early? But I think we have the efficacy data, and we do see also, I think, the tolerability. I had a couple of patients in the IMforte trial, and they were doing quite well with the combination, unexpectedly well, I have to say. So this was, I think, surprisingly well-tolerated therapy. So when you look on your patients, how would you select your maintenance strategy? Do you have any factors? Or would you say this could be something for the majority of my patients undergoing the first-line chemoimmunotherapy? Is there anything which is of importance in monitoring these patients? So what would be your recommendations there?
Well, the forest plot showed improvement in all subgroups. So I think we should feel free to consider the addition of lurbinectedin in most of our small cell lung cancer patients. For those that need break after chemo and immune therapy, perhaps for them, second-line lurbinectedin makes more sense. But for the most part, patients are surprised how well they tolerate first-line chemotherapy, carboetopicide, with immune therapy, and they're not ready to stop with treatment at the point that we go to the maintenance immune therapy. So for most, I will begin to talk to my patients about the addition of a booster to the immune therapy on its own.
Yeah, but I think it's still very important to educate our patients that it's a chemotherapy. So we still need to monitor them, we need to collect the blood samples and so on and so on. But with that, I think it's a great opportunity that we have achieved now for our patients.
In some ways, I think it might even be easier to give because patients are used to having GCSF support after the chemotherapy in the front line. So for many, be a continuation to continue prophylactic GCSF or GCSF after a neutropenic event. And most are in possession of antiemetics, and so they know when to take them. We've taught them to do that in the front line. So I think it will be a seamless transition, maybe even easier than waiting till second line.
Let's switch a little bit the topic. So now we have this one concept, IMforte. Hopefully it will be available very soon for our patients in different parts of the world. But we also have the concept of the T-cell engagers. Tarlatamab is one of the prominent examples. We have seen the efficacy in pre-treated patients in the phase 2 trial. We have very early reports of the randomized trial in phase 3 trial in the pre-treated patients. But now we are also moving this into the maintenance field. What are your thoughts? What are your taken about this new strategy of combining T-cell engagers with the checkpoint inhibitors in the maintenance field?
You know, when I watched Sally Lau present this phase 1b data at World Lung last summer in San Diego, I thought that is a smart strategy, because here again is a place where we don't have a great option beyond immune therapy. We can sense when patients are either not completely done responding to chemo, or perhaps are already developing platinum resistance and will need another agent. So it makes a lot of sense to try adding the tarlatamab and other bispecific T-cell engagers to immune therapy. I was surprised to see very little in an increase in toxicity when we add those two immune therapy strategies together. They seem to be very well tolerated, and as you said, most of the CRS happens in that first cycle, which is what we know to be true for tarlatamab alone. So I think this is another very easy conceptual slide for me. And we'll need to see the results of the larger Delphi 305 data to know that what we saw in the phase 1b is true, also with a randomization in the 305 effort. But I'm excited to see that.
So currently it's an exploratory trial, so predominantly we have looked on safety and feasibility of this combination. There are encouraging signals of efficacy. I think you have a lot of experience with tarlatamab in pre-treated patients. Just to explain, what does it mean for the patient from a real pragmatic view to treat someone with tarlatamab? I think he has to come very frequently to your side, so you have to monitor him. It's not that easy treatment for every patient. Perhaps you can share a little bit of your experience there.
That's true, but I will say that as we're beginning to use tarlatamab more and more in the standard of care setting in the US, we are finding it's actually easier than the clinical trials made it. So for example, in the clinical trials, all patients were required to be hospitalized for 48 hours after the first dose, cycle 1, day 1, day 8, day 15, and into cycle 2. Now we're moving to more of an outpatient strategy where patients are not hospitalized, but instead have a 6 to 8 hour observation in the clinic. At the discretion of the investigator, sometimes that observation is lengthened to 23 hours, but much less. There is increasing efforts to have the patient stay near the site, but not be in the hospital. We send patients home from the clinic with a blood pressure cuff, with a vital sign, with a pulse oximeter, with a temperature probe, and 1 tablet of dexamethasone.
Okay.
So if they are to begin developing side effects that we are concerned might be CRS overnight, they can do something about it. We educate the patient and the caregiver about temperature and low blood pressure being the two side effects that we can measure, as well as the pulse ox, as easily in the outpatient setting as we do in the inpatient setting. That said, this will not happen immediately at all centers. And so importantly, collaboration with the hospital setting, if you've built that infrastructure, is critical to the success right now of using this drug.
But we are learning, we have to learn, which is good for our patients. I think we have seen a substantial next step with this combination of lopinectedin and atezolizumab as a maintenance strategy. For a long time, one trial showing significant improvement in progression-free survival and overall survival. And just to remember, we are talking about metastatic small cell lung cancer. When we look on the Congress data of the recent months, small cell lung cancer really has gained attraction. So we have a lot of new concepts there in investigations. Perhaps at the end, what are the most attractive compounds that you see in the future for small cell lung cancer?
I think the thing I look forward to the most is understanding the sequence of these novel therapies, because I don't think it will be the same for all. We will find clinical predictors markers like disease turnover, rapid progression, that may lean towards more of a cytotoxic preference in the maintenance setting, where for others that show no evidence of progressive disease by radiology, perhaps that's a patient for which a bispecific T-cell engager will make more sense. I think the antibody-drug conjugates are of import, both the IDXD as well as the SCZ6 ADC, even TROP2 ADC is making a run. So there's a lot that we still don't yet understand, a lot to be excited about in small cell lung cancer.
But it's fantastic to see that there is movement in small cell lung cancer. For decades we had nothing, and now it's like an evolution. We do see a lot of new therapeutic options. Melissa, this was a fantastic discussion. Thank you for all your insights and for your thoughts. And I would like to thank you for participating in this activity. I would like to invite you to continue to answer the questions and complete the evaluation. Thanks for attending this Medscape program.
This program is presented by Medscape Education Global.